hollow vest. Like they asked Haruna was to hollow vest. Because myself in my practice, I only assisted once in a hollow vest. But I saw the one that you did, Prof. Haidara. I was just going to ask, is it a locally produced one? And if it is locally produced one, is it accessible? And also, what is your experience with people using it in this region with regards to the heat and the sun? The second question goes to the one that did the spinal cord injury. I wanted to ask if you have high cervical spinal cord injury, especially those affecting the phrenic nerve. The patients come with abdominal breathing, phrenic nerve injury. Even if it is within the first 6 hours, do you go on to operate?
It's a local production, and it costs around $100. The patient has a factory in the hospital, and the patient went there to take measurements, and he tried after, and they make the final harvest. But it's supported by person, I think, because I don't know what is the material, but as you know, because of the sun, is often difficult to keep such equipment, but usually the patient support.
On the side that you have a lateral mass that has been avulsed, can you tell me what's your experience in getting that screw into that place? What are the nuances? What is the difficulty? And how do you really go and fix the screw in that extent?
When the lateral mass is intact or not intact?
When the lateral mass is not intact.
You ask why I put the screw in the lateral mass?
No,
not intact?
No, like the example you showed.
Yes.
There was C1 Jefferson's fracture.
Yes, there's a fracture on the right.
Yes.
Lateral mass.
You still put screws into C1.
Yes, yes.
Yes, so I was just asking, what are the difficulties that you face
Okay.
putting those screws in C1?
The difficult when the lateral mass is fractured.
Yeah.
Okay. So it's difficult. I agree, because you have to appreciate on the CT scan when the lateral mass, a part of lateral mass, because the screw 3.5 millimeter, that's small. So you must do on the plane, on the previous CT scan, if you the part of lateral mass, the rest of lateral mass can take the diameter of of the screw. That is our process.
It's not necessary to make urgently MRI. Why we can do to make a classification of a slight classification, because we have in the classification ligament injury and the plate radiographic. Okay, yeah.
Perfect. Okay, so I just need to make one very, very clear comment. The initial management of a patient that comes to you with a unifacet or a bifacet dislocation involves getting a plain radiograph, and that many centers are able to do, and then to proceed to a reduction thereafter. There are select patients that you don't want to put on traction, and you just need to be wary about. For example, you have an old man that comes to you with ankylosing spondylitis. You don't want to just pull him out. But pretty much in the vast majority of patients, you get your x-rays, you make a diagnosis, and then you proceed to put on skull traction, and then to try and reduce the fracture. In those patients, what I had mentioned was we have very clear-cut data that doing an MRI before that process is expensive, it wastes time, and it doesn't change the outcome. That's a very important thing, because whatever imaging we do needs to have an impact on our decisions and finally an impact on the outcome of that patient. Now, once the patient has been reduced, and the important thing is, wherever you are, and if you're able to ask for, try and get cones calipers that are MRI compatible. It's very important. And I recently had a case where somebody had put in a stainless steel one and then tried to take him to the MR. And the patient literally got stuck into the scanner. So get MRI compatible cones. Please ask for them. Once the patient has been reduced, get your MR. Because a lot of the decisions you then make about posterior ligament structures, whether they're intact or disrupted, you then have on your MR. Okay, does that help? Perfect. Look at things. But like I mentioned, the reason for having a classification is that it needs to be, one, a way for us to talk to each other. Now, with the current AO, it's so easily accessible. If I ask somebody about the AO now, it's very easy to just, even if one doesn't remember the exact points, we've seen apps that can show us. We can there are PDFs available for download that we now look at, and then it's easy for me to say I have a type B2 injury to you on the phone, and you can see it. It's very hard to do that with the multimeter. So for ease of communication, that we're all on the same page, that is why the AO came about.
To Dr. Ono, about the case of thoracolumbar trauma.
Yeah.
I saw you put pedicle screw in 3 level upper and 3 below. Generally, people prefer to add a short fixture. Why do you prefer 3 instead of 2 level, for example? 2 level upper and 2 level.
Question is very short, but the answer is too long. According to traumas, okay, you have 2 choices. One, the combined surgery. You may use posterior fixation with anterior device, okay? But if you don't prefer to do the combined, so this 360-degree surgery, if you do the surgery, you have to make a long fixation, okay? It means at least 2 level up, 2 level below, or you may go 3 level up, 3 level below, okay? If I had done this surgery now, okay, I have stopped at T9, I will not stop at T9. If I do this surgery now, I will go 4 up. Okay? 2 choices. Short segment, 1 above, 1 below or anterior. I prefer posterior surgery, so you have to do long segment. Long means more than 2 levels. Okay? 3 up, 3 down. Okay? So you have to decide at the apex of the thoracic spine there. So I have stopped at the wrong level. It was T9. I have to stop at least at T8. If I done this surgery now, I will do T8. 4 levels.
First question is to know how long we can continue a conservative treatment for odontoid fracture type 2 after magnetic resonance imaging showing an integrity of ligamentous junction joints. This is the first question. The second question is about the lesions of ankylosing spondylitis of craniocervical junction. Sometimes after trauma, after craniocervical junction trauma, patients can develop ankylosis spondylitis of this region, and these lesions can be responsible for spinal deformity. If we must perform surgery, what can be the goal of the surgery? the goal can be to restore the spinal correction of this region, or the goal can be to release the ankylosing spondylitis of the region, or the goal can be the both. Or the goal can be both of them. This is my questions.
I think it's not a good indication. It's not a problem of ligament. Because if you have a fracture of type 2 not way, when you make you don't need to make the dynamic, but if the patient is not, it's an unstable fracture. If the patient moves forward, the other leg will go forward and have a section of the spinal cord. I don't know if you see. You see what I mean? Okay, there is unstable fracture. The indication is not conservative. And you can make arm technique to fixation. For the second question, say if there is trauma, and all trauma or yes, with deformity, and what symptom?
If there is a automatism which is responsible of an ankylosing spondylitis of craniosacral junction, sometimes it can be responsible for spinal deformity, such as cervical kyphosis. If we must perform surgery for this kyphosis, the goal, what can be the goal?
What type of adhesion when initial trauma?
Craniosacral junction trauma.
Yes, but what kind of trauma?
Such as laminar fractures, Jefferson fractures. If the initial indication has not be suitable, sometimes if the patient has this traumatism in some far areas, he has not had the chance to meet the neurosurgeons, and if the patient comes secondary to a consultation to see a neurosurgeon, and we observe that there is an ankylosing spondylitis of the craniosacral junction with a spinal deformity. What can be
neurologic deficit or
no neurologic impairments.
Okay.
What can be the goal? The goal can be to release the craniosacral junction, or to correct the cervical or the spinal deformity, the kyphosis, cervical kyphosis.
I think it depends on the type of lesion and the situation of the consolidation. Well, when you have, for example, odontal fracture who is not consolidated in abnormal position, it's more mobile, you can operate to have an realignment because it's not fixed. But if you have a consolidation in abnormal position, it depends on neurological situation. I think if the patient has a spinal cord compression, you can make the compression and stabilization, postural stabilization, and you can complete with anterior decompression. Okay. You want to add something? Yes. If you talk about deformity, the rules change, okay? So don't think like at a trauma, okay? Then you have to make the measurements. You have to measure C2, C7, SVA. You have to keep the difference between T1 slope and normal lordosis. So maybe you will need, I'm talking about the chronic, okay, the deformity. You may need ponteosteotomies to correct the spine. You may need maybe C2 pedicle substruction osteotomy. It's totally different, okay? Don't think trauma as a deformity. If you're talking about deformity, the rules change, okay? You may combine 540 degree surgery, ponteosteotomies, anterior cervical devices, and come again to posterior. Maybe you have to just add a C7 pedicle substruction osteotomy, okay? The aim is there, get a good cervical lordosis and to keep the horizontal raise. The rule changes there, okay? About it's totally different about the upper cervical trauma, okay? The patient may have, there are cases, they are rare, with upper cervical trauma, and they have cervical deformity like chin chest deformity like that, okay? Then you have to do different surgeries. Posterior, anterior, posterior surgery, or anterior, posterior, anterior surgery, okay?